Thank you. Thank you for introduction. Thank you, BOC, for giving me opportunity to speak over here. Today, I'm going to speak on some three interesting case. That is like how we are managing with you can say it's not a rare, but it's some difficult, challenging cases. So that I'm going to discuss. So before that, going. So we need to know what exactly is a neurooptometry, and Dr. Skiffington, Professor Skiffington, first describe the behavioral model of vision, and that is not only to in visual acuity, that is related to your identification, anti-gravity, which is very important. Third, that is speech and auditory, and your balance. So when we are assessing any type of vision assessment, as a vision means it's not only a visual acuity, like it's not a 20/20. We are just working beyond 20/20, right? So we have to be very crucially, you have to see, you have to understand what is the patient problem and how you can help that particular patient. So you can say this is one type of rehabilitation. And one more important thing, as a optometrist, you are not only the as a working professionals, always you have to take some help of other professionals also, which is very important. Sometimes maybe you need a neurologist, or maybe a physiotherapist, or occupational therapist, or speech therapy, dietitian, nutrition. So whole lot of is a holistic approach. So whenever you are managing this type of conditions, so always you have to take a support, or maybe you have to consult with them, or maybe you have to refer to them. So neuro-optometry is nothing different. What is the difference? So difference is you have to be assessed total visual process, right? So when you see we come to a patient with come with headache, or patient with come with nystagmus, or patient with come with traumatic brain injury. So generally what we see, we are just only see how much visual acuity is there, 6/6, and see we are trying to reach 6/6. So rather than reaching only 6/C, so you have to see the how patient quality of life you can improve. So quality of life means it's not only visual things. So along with that, there how a patient is supposed to work in office, and suddenly after stroke, patient is not able to do anything, right? So you have to understand that psychology of that particular patient. So it's you have to work on sensory motor, accommodation, oculomotor function, and which I'll already explained, that is called visual information process. So when you talk about visual information process, again whole lot of things that start from bilateral integration, laterality, directionality, visual perception, visuomotor integration, intersensory integration. Then you can come across with some conclusion. Okay, yes, the patient have this type of issue is there, or patient maybe require these things. And also when you as I mentioned, when you talk about therapy also, during therapy, always you have to be take a help, or maybe consult with other professionals. Now why neuro-optometry, why neuro-optometry is required? Because as I told you, when you are as like just an example, like we how we'll do the what dot, we do distance and near, right? We do that. What you do, we do in static condition only, but what we are approaching here, always we have to do in the dynamic condition. So when you are assessing any type of patient, so always you try to do dynamic things. You have to work on balance, you have to work on perceptual, you have to work on many things, many intersensory integration. So all patients suffering from any neurological disease, and that you need to be work on that, and you have to be preciously assessed. So what are the conditions? Basically, we consider in this neurooptometry field, the first and most important, that is called concussion, or that we'll see in post-traumatic vision syndrome. The traumatic brain injury can be a after stroke also a traumatic brain injury, right? So any type of traumatic brain injury, or it may be a psychological trauma, or stroke patient is coming to our clinic. So how to assess that? That is neuro. Anoxia patient, dementia, stroke, seizure disorder, Alzheimer disorder, Parkinson disorder, cerebral palsy, autism, multiple sclerosis, visual field loss, and nystagmus. You will see when you see any traumatic brain injury patients, so you will see whole lot of other component you need to be managed. So if you do a assessment, so basic assessment is as you do a refractive, that is only refractive, not only the option. Always you have to see in binocular vision, that is cyclic pursuit, fixation, vergence, oculomotor, and also you have to see the non-oculomotor based problem, which is most important in these cases. So what is that? That is something is called abnormal spatial localization, photosensitivity, motion sensitivity, vestibular problem, visual field defect, and visual information process problem. So this is very very important, which will change the patient, once again their lifestyle, say, or whatever you can say, life habituals, right? Also you have to be concerned about oculomotor things like vergence accommodation, and as I mentioned, always you can counsel like non-visual based problem, like patient have a depression, patient have a fatigue, or maybe cognitive problem is there, or behavioral problem is there, or postural problem is there. So always you have to be consult with other professional, or may you have to refer to them. So these are the cases. Is one cases in is came to my clinic, and the patient has been 3 times stroke has been done, like 2019, 2020, and 2023. Patient was referred from some hospitals, and patient was both eye was pseudophakic, and visual acuity was only finger count 3 meter in both eye. Oculomotor was good, pupil round, sluggish, and reacting. Macula that had been diagnosed already in hospitals, and CDR ratio is 0.3. Minimal temporal pallor was there. The glasses was 2 with 0.5 90 degree, and left eye is 0.5 with 1 cylinder 90 degree, and addition was 2.5. So what visual finding we have seen? Visual acuity, as I mentioned, cover test was around 6 to 8 exophoria, and fusion patient was showing fusion in suppressing in almost all gauge, and we have checked in stereopsis, in random stereopsis, central stereopsis was absent. Eye movement was poor, circuit and pursuit was there. Balance test, patient is not able to conduct because patient is just 3 times stroke. If you see the video, I'll show the video. Even patient is not able to. The patient don't have confidence to walk also, right? So slowly that will change. And then the most important, which I would like to say, that is called visual midline. So we have a imaginary visual midline is there. After traumatic brain injury or any type of neurological insult in the brain, the midline, if it is shifted, maybe left, right, or anteriorly or posteriorly. So you will see, after stroke, patient is not able to walk properly. They are not able to climb the stair. So you see, they don't have confidence. They don't have confidence to cross the road also. And I have a patient was in office, patient was walking, and simply stroke, mild stroke is happened, and after that patient don't have confidence to walk, patient have confidence to do anything, right? And you have to be very carefully, you have to listen the patient, what are the problem they are suffering, what are the other things the associated, that you need to see. And perceptual test were not able to perform in that condition. You can see this video. If you see, the patient is, the patient is tilted this side. If you see, this is without yoke prism. I'll just show you once again to follow it. So if you see the posture of the patient, see this, the patient is tilted this side. Okay. So when patient they came, and what I have prescribed, and I have prescribed 2.25 refractive. Along with that, what I have prescribed yoke prism. So what is yoke prism? So yoke prism is the prism which is change the person posture and behavior. So I have prescribed 2 prism breast right, 2 prism breast right, along with 2.5, that is the addition, and also I have advised binasal occlusion and 30% of amber tint. These are some activity. What activity we have done? So we have done medial visual midline training with four base right for as a yoke prism. Also, you have done with second pursuit training, pegboard with SBI. We have done syntonic light therapy with MYOPTOM, blue, that is blue and green, perceptual therapy, and accommodation with flipper and art chart. And after almost patient still in my clinic and the still therapy is ongoing, and after 28th session I was surprised. Why I'm surprised, even I don't expect patient visual acuity is how much. It was only finger count 3 meter, and when we done the refraction, visual acuity was 6.9 with 2.5 and 6.9 1.25. And Watford dot fusion was present in both distance and near and all gauges. Stereopsis was 50-second of arc. Accurate or accurate, pursuit or accurate, visual midline. Lot of changes is there, but still there is a we need to work on that. And so I have advice for the continued therapy. But the most challenging thing, what I'm feeling the challenging, that is the patient visual memory. Still, we are not able to figure out how you can recover the patient visual memory. But there is a lot of changes is happened. Patient previously not able to do anything. Now patient is doing some little bit home activity, or maybe patient is visiting to park. Little bit activity patient is started, and you can see the patient posture, how patient is walking now. So this is the with yoke prism. So we have prescribed yoke prism. Still little bit tilt is there, you can see, but patient is quite better. Patient can walk and visual acuity is improved. Patient is very happy. Patient is now doing the other activity also. The next important and very interesting case, that is of case of nystagmus. So the patient was 11-year-old, and the patient mothers were complaining about poor eye contact, poor fixation, jerky nystagmus, limited of span. Academics is not good because visual acuity is decreasing, and birth history was only 6 section, otherwise normal. So when we assess the visual finding, so we see the visual finding, that is 6/36 in right eye with PGP, and similar left eye was 6/60 with the PGP, and refraction was there is no such much difference. Stereopsis, central stereo again it was absent. Fusion was all suppression in all gauge. EOM is full in all gauge. Eye movement was jerky. Null point in primary gauge. And when you try with yoke prism, again the nystagmus, amount of nystagmus will decrease. So we have prescribed and other things we need to see, like a bilateral integration, that is we have done with the standing in snow angels, and along with that patient motor flow is there in both IFSI and contralateral test. Prematic reflect was little bit poor, and VOR was normal, patient was reflexity. Cover test was distance or ortho, near was very difficult to measure, as you know, in the nystagmus, so in and around 2 to 4 exophoria was there. So I have trial RGB lenses, as you know, in case of nystagmus patients. So better if you give a contact lenses, so the visual outcome will be better. But patient intolerant, because patient is only as 11-year-old, so we are not we are dropped about the RGB lenses. So we have prescribed glass with 0.5 with 0.5 with a 2 prism base down and 2 prism base down in both eye. And I have advice for vision therapy and vestibular training around 40 to 60 session. Prematic reflection training was advised, and fixation therapy. So actually, this is not a patient real video. I have the video. I'll show you the pre-post changes. Patient was not given consent, so that's why I'm not able to keep the patient faces over here. So pursuit therapy, we worked on first pursuit therapy, that is with pegboard activity and Merson ball. And then psychedelic therapy, you can see the video on that little bit, so you will get idea. So this is basically for to improve the pursuit one. This is to improve the, this is a hard chart. This is to improve the psychedelic eye movement. So patient here you have to read the only the first letter and last letter. So let's say A, K, B, C. That is improve the patient psychedelic eye movement. This is again it will work for both. This is for the pursuit and circuit both. The another therapy we have, advised, that is anti-suppression therapy and by some binocular activity. So this is some, some video of this is Tanaglip activity. So patient, the patient have to just fix it and they have to maintain the single. So you have to just increasing this way or this way. That is for convergence and divergence. So basically, in case of any nystagmus patient, always you have tried to increase the convergence demand. Similarly, this is the another activity where you can use a random approach. Similarly for convergence and divergence, and this is something is called Barnelloscope, where also you can train for convergence and divergence. So, after 50 session of therapy, it will take too long time to achieve visual acuity. So that was 6 by 9 and with zero point 0.5 in one cylinder, zero point 0.5, and stereopsis was quite good, 50 seconds of arc. Fusion was present in all gauge of distance and near. Fixation was quite good in mainly in the primary gauge, not in all gauge. Still in all gauge, still the and cover test were. So this is the changes. As I mentioned, patient was not given consent to show the video, so we are trying to because nystagmus patient we don't have any option to show you. So if you see, this is the pre-therapy video of nystagmus. So you can see here. So this is the, and this is the post therapy of the patient. So you can see the changes. Right, so this is one. The one more another case, that is case of six nerve palsy. So basically, frankly speaking, I don't get time to make the study of case study of this patient. So I have just made a video, and you can see like how is the changes after therapy. So patient actually 56-year-old, and patient was history of diabetic retinopathy, and the patient visual acuity was 66 with the vision, and it will take 32 session in duration of around 4 months to get achieve this condition. You can see the pre-video and both the video is combined with them. So you can see the left. If you follow the left, is not is restriction was there, and you can see the changes of after therapy. So it's moving nicely. Okay, so these are the three cases, is some interesting cases where I'm going to present. So thank you so much. And one more thing, one just to overview of my clinic, how we are working over here, like what are the conditions we are doing. If anyone have any query, I'll be happy to answer. Yes, please. Yes, sir. Is in Godihat. Anyone have any query? And Pujolda is here. I'm thankful to Pujolda. This patient, like traumatic brain injury patient, Pujolda only referred to me, and thank you for trusting me. Is 6'9". Yeah, please. See, basically, when you are working on strabismus, so you have to work on all gauges. So you have to this gauge straight, and yes, yes. So we do in all gauges. We do in all nine gauges. So we are, giving service not only the vision therapy. Along with that, we are doing a specialty contact lens along with low vision and ocular prosthesis. Recently, we have started customized ocular prosthesis also. So anyone have any query? Yes, please. Most welcome, sir. সাউন্ড চলছে না তো অডিয়েন্স বোর্ড হচ্ছে না সাউন্ড চলছে না এইবার চলছে And one important thing is we have started fellowship and internship program that is comprehensive 2 years internship along with 1 year fellowship. So 1 year clinical internship and 1 year fellowship. So if anyone is interested from the students, so they can contact to Refocus team. Thank you so much. Once again, thank you for the opportunity.